Okay, our next speaker is Dr. Kopecky. Dr. Kopecky has been kind enough to come for several years now. He is professor of medicine and chair of education in the Division of Preventive Cardiology, Department of Cardiovascular Medicine at Mayo Clinic in Rochester, Minnesota. He serves also as the director of the Statin Intolerance Clinic. Dr. Kopecky received his MD degree at University of Texas Health Science Center in Houston, continued his cardiology training and fellowship at the Mayo Clinic. His interests include lifestyle on development of cardiovascular disease. His research involves new treatments for elevated cholesterol, especially in patients with genetic abnormalities as the cause. He's a highly acclaimed national and international speaker on cardiovascular disease, and he's the author of the best-selling Live Younger, Longer: 6 Steps to Prevent Heart Disease, Cancer, Alzheimer's, Diabetes, and more. He has authored numerous journals, book chapters, and in recognition for his achievements, recently received Teaching of the Year Award and the Jan Kellerman Memorial Award for his distinguished work in the field of cardiovascular medicine. He has served as president of the American Society of Preventive Cardiology and currently serves as international advisor for the Foundation of Global Community Health. Interesting topic today: what are the SMuRF-less heart attacks, and can we prevent them? Thanks for making it again, Steve.
Thank you. Well, thank you. It's a great pleasure to be here. The weather is still better than where I came from in Minnesota. As you can see, I'm in Rochester, Minnesota, where when it starts to rain, it usually turns white about halfway down. I'd like to speak to you today for the next few moments and about SMuRF-less heart attacks. And what are SMuRF-less heart attacks? This is something that came up a few years ago. And I've been watching it for a few years, and I thought it would go away, but it keeps recurring. And they've actually written guidelines for how to treat SMuRF-less heart attacks. And we'll talk about some of the aspects of it. But first, a couple of things. The disclosures are here. The objectives today will be to understand the definition of the standard modifiable risk factors, also pen named SMuRF. So if you have a SMuRF, that means you have risk factors. If you don't have a SMuRF, you're SMuRF-less, then you have no risk factors for your MI. Recall the trends in SMuRF-less MI occurrence, and then recognize opportunities for prevention of SMuRF-less MIs. As many of you may know, Framingham was the group that really taught us all about risk factors. And it was Bill Cannell, that wrote the first article with Joe Stokes, where he didn't call them risk factors, he called them factors of risk. And we had factors of risk in many diseases, but this really stuck with heart attack because it was starting to be, after the war in the early 60s, starting to be the #1 killer in the country over and over again. And they did a follow-up study, 6-year experience, and they taught us things that are still true today. This was on the x-axis was cholesterol, the y-axis was their 6-year incidence of coronary heart disease. And these lines that you can see here are lines that actually are the systolic blood pressure. So the higher the systolic blood pressure, the greater the risk, depending on what your total cholesterol was. In those days, they didn't use LDL. And what it points out is that as you add a risk factor together, it gets much worse than a single risk factor alone. And that's been true in just about every risk factor we look for in coronary disease. And there's been, if you look at the searches on Google Scholar, you'll find there's about 250 different risk factors reported for coronary artery disease. And we pay attention just basically to 5 of them. In those 5, really, 4 of them are here. And that's identification and treatment of diabetes, hyperlipidemia, hypertension, and smoking. And that's what really the Framingham came up with initially. They also talked about family history, but it wasn't such a big deal to them at the time. It kind of grew over time. But these 4 risk factors were called the main ones at the time, the classic risk factors. and they've been effective at decreasing the incidence of coronary artery disease. But in 2014, this article came out in Lancet, which is probably one of the best, if not the best medical journal in the world. It said, but cardiovascular disease remains the #1 cause of death. Or are we missing other causes? They said this is basically 60 years after Framingham. Why are we still having all these heart attacks, and why is coronary artery disease still the #1 cause of death? Remember, during COVID, the #1 cause of death was coronary artery disease. My sister died when I was in training at Mayo in cardiology of breast cancer. And you know the #1 cause of death in women with breast cancer is coronary artery disease. The #1 cause of death in men with prostate cancer is what, Mo? Coronary artery disease, right. So it's really coming for all of us. And so you just heard a great talk about coronary calcium and differentiating high and low risk patients. But let's not fool ourselves, I mean individually as patients, that we're all at risk. Now, SMuRFless versus SMuRF heart attacks, why could there be SMuRFless? Why is that even an entity? Well, there could be three possibilities. First, that the classic risk factors I just talked about are not being treated adequately, or the treatment's no longer effective, or the patients aren't taking. Does statin intolerance ring a bell? Minor risk factors, so factors that previously were known are now becoming more lethal or prominent. Things like depression, stress, lack of sleep, that we used to not even think about or thought they weren't very important, now we're finding they're incredibly important. And who isn't stressed in the last 3 or 4 years? Or could there be new risk factors that we didn't even know about? Things like lipoprotein A that's just come along in the last 15, 20 years that's come into prominence. And if you look at the cardiovascular mortality trends for the US males and females, this is from 1980 to 2020. And remember, the peak of cardiovascular death was 1970. It started going down about 1970. Hit its nadir at about 2010, as you can see. And this slide really shows all three of those factors I just talked about. One was, what was this bump right here? Well, after 2019, it was COVID, obviously. That went up because the inflammatory response to COVID set up a lot of heart attacks with inflammation and plaque rupture. But then, if you look at starting in about 2010, there was a recent Reddit study looking at about 10,000 mentions of statins, of which 98% of the mentions were negative. And you may say, Reddit? God, who reads Reddit? 30 million people a day, 54 billion people a year read Reddit. And so that could account for some of these problems that we're not taking our medicines. And there are other diseases that are new that are come along, the stress, the lack of sleep. We do this great social experiment every year. We just did it, 2 or 3 months ago. It was called Daylight Savings Time. And as you're probably aware, the Monday following the Saturday of Daylight Savings Time, STEMIs go up 27%. In spring forward. When spring back, when you get an extra hour of sleep, the Monday following, nothing happens, but the Tuesday following, heart attack STEMIs go down about 20%. So we never quite, and you never can make up an hour of sleep. If you miss a meal, believe me, we'll make it up. We'll eat the calories. But you don't make up an hour of sleep. So in 2017, an article came out from Australia that confirmed no standard modifiable risk factors. And you can see they pointed out no high blood pressure, no high cholesterol, no diabetes, no smoking. And let's look at what happens to these folks. And it was an article in the EJPC, the European Journal of Preventive Cardiology, which is an excellent journal. And they said an increasing proportion of ST elevation MIs occur in patients with poorly explained risk factors by the standard risk factors. And this was from Sydney, Australia. In Sydney, Australia, many of you may know about Australia, that it's had some great medical finds. Remember H. pylori, the infection that causes ulcers, and initially they were ridiculed and laughed at meetings, and that a bacteria could cause an ulcer in the stomach. They also came up with things like atrial fibrillation, that if you exercise regularly, it cuts down atrial fibrillation 60%. Who would have thought? And lose weight. Who would have thought that was beneficial? But Australia is an interesting country And I'll talk more about that in just a moment. But what they found was that SMuRF-less STEMIs do occur, and they looked at this from a time point of about 26 up to 2014. And in 26, you can see the SMuRF-less incidence was 11%, increased to 27% by the end of 2014. This was a single-center retrospective study. It was consecutive STEMI patients, and the STEMI was their first onset of CAD. And that's what this specifically talks about. First onset CAD, first MI, it's a STEMI. That's all that SMuRF-less talks about. It doesn't talk about NSTEMIs or people that maybe have multiple recent episodes of coronary disease. And they found a 12% increase a year, and that the extent of coronary disease was not associated with SMuRF-less status. In-hospital outcomes was not significantly different, and discharge diagnosis was not significantly different. So they really just kind of threw this out there and said, this may be a real entity we need to start paying attention to. But again, this is kind of like what Australia does. And Australia is a wonderful country with wonderful people. But you know why they started was that Britain took them over, and the reasons that led to the British to invade Australia were simple. The prisons in Britain had become unbearably overcrowded, a situation worsened by the refusal of America to take any more convicts after the American War of Independence in 1783. And Australia has always, in a very good way, very positive, productive way, said, we want to show you that we are different. We will find things that other people don't think of. And that's a great attitude, I think, to have, especially in science. So are SMuRF-less definitions, though, for coronary disease the same as we use in guidelines? And this is very important to understand. If you look at the thresholds for the definition of SMuRF-less, in that article I just showed you and the subsequent ones I'm going to show you the next few minutes, hypertension was called over 140 or 90. Diabetes, hemoglobin A1C, that could be up to 6.5%, was felt to be normal. And lipids, LDL, less than 135. And then current smoker was smoking within the last 12 months. If you look at guidelines, it can be a little bit different, though. Cardiovascular guidelines in multiple societies that write guidelines around the world have said that cardiovascular guidelines, the blood pressure should be less than 130/80. Remember, risk for a heart attack increases above a systolic of 115, 115. Many patients come to me and say, oh gosh, my blood pressure is too low, doctor, it's 118. And I'll say there's no such thing as too low unless you get symptomatic. But actually 118 is a little too high. Hemoglobin A1C, less than 5.7% is what we accept as the goal. And the LDL goal, if you don't have coronary disease, is less than 100 per current societal guidelines. And if you do have CAD, it should be less than 55. So the SMuRF-less, and the smoking is a very reasonable definition for smoking within the last 12 months. In fact, many guidelines actually say just the last month. But as you can see, the SMuRF-less guidelines include patients we wouldn't include as not having risk factors. And that's important to remember. So SMuRF-less definitions of hypertension, diabetes, and hypercholesterolemia are significantly higher than what is currently used in guidelines. But they did subsequent papers, again from Australia, and pointed out this was now 2 large sequential multi-center registries, about 3,000 patients. And you can see that females and males, it was a little more common to have a SMuRF-less heart attack if you were a male than if you were a female. The age was in the early 60s. And very interesting, you can see that the standard risk factor treatments, diabetes, hypertension, lipids, smoking treatment, or current smoking, were all 0 to their credit. They really did include truly what they defined as SMuRF-less. And the statin use, medication use, et cetera, was very low. There were some patients on aspirin, some on platelet inhibitors, but in general, these were truly patients that at least hadn't come to the attention of the medical establishment yet to be treated. But their in-hospital mortality and events, you can see that SMuRF-less was a little more likely to get an angioplasty, but the SMuRFs were a little more likely to get lysis. Remember, this is in Australia where every institution didn't have it, so they would then transfer patients, and you can see they made it up and transferred to other hospitals. Mortality that was not statistically different, which I don't understand with 3,000 patients, but after age and risk factor adjustment, it didn't pan out. But a 50% increase in mortality does seem significant to me. We'll talk more about that in a moment. And then post-hospital, there's no difference in treatment or outcomes. So the SMuRFless, they had a higher mortality, not statistically significant after the, it wasn't randomized, but after the multivariate analysis. But the 6-month MACE, there was no significant difference in major adverse cardiovascular events. Although it was 27% higher. Again, it was not, the p-value was not quite to significance. And they said something that is very scary. You ever watch a horror movie and the bad guy is just getting ready to get killed by the good guy, and right at the last scene, the bad guy all of a sudden disappears. and the good guy says, oh my gosh, where'd he go? Well, you know there's going to be a sequel. And they said, further study needed. One of the scariest things you can read in academic literature, and you know more is coming. So in 2021, this is from Sweetheart, same authors or same main author. They looked at some Swedish registry from the Sweetheart study, 9,000 patients, 15% of which had STEMIs that were SMuRF less. And you can see that men in red and women men on the left, SMuRFs are in red, SMuRF less are in blue, that at 30 days, the SMuRF less actually had less survival. Women, the same at 30 days. And at 12 years, they followed them obviously a long time. There was a significant difference, and clinically significant difference, and statistically, in mortality with the SMuRF-less patients not doing as well at 12 years. So again, this started to bring up other ideas. So survival was lower with SMuRF-less in females and males at both 30 days and 12 years. So then an article was written that was, in addition to this journal article, there was an editorial that said, why me, doc? The authors said, we are interventional cardiologists driven by the increasing number of heart attack patients who look up from the cath lab and ask me, why me? And they particularly pointed out the difference in women that have less survival with SMuRF-less heart attacks. So again, we knew this was a very important topic that needs to be followed up on. What about ethnic groups? Well, ethnic disparities in SMuRF-less. From the MNAP, the Myocardial Ischemia National Audit Program, or project, which is 118,000 patients, SMuRF-less was again about 25% as it was defined, with no difference in in-hospital mortality, odds ratio of 1.05, and no significant difference in outcomes according to ethnicity. If you look at an Asian population, we know that some of the Asians, especially South Asians, have much higher risk for the same risk factors. That this was from Pakistan, again, consecutive, almost 6,000 patients. They found that the in-hospital and 5-year mortality was not different in SMuRF-less after multivariate analysis. So the ethnic groups, it didn't seem to make much of a difference. What if you were a young SMuRF-less patient, meaning less than age 45? They looked at patients here with STEMI. They were in the 18 to 45 range. Average age was 42, 85% were men. And you can see that the 30-day survival in the SMuRF-less was less, and the 30-day MACE in SMuRF-less was also less. But they found that the patients that were young that had SMuRF-less had much higher intensive treatment. They had higher cardiac arrest, 28% versus 13, almost double, 5 times as much mechanical support. ICU was used 3 times as much, and left anterior descending was 50% greater as the culprit lesion. So young SMuRF-less, their 30-day mortality, the hazard ratio was almost 5, and they remained significant at 2 years post. So there's something different about the young patients that have SMuRF-less MIs as defined here. And this study also came out about the same time in young SMuRF-less patients, and they are characterized by very high inflammatory markers, not CRP necessarily. In fact, the CRP was not different in the patients that have SMuRF-less and SMuRF. But they did look at other cytokines like interleukin 10, which is one of the markers that's really one of the key directors of plaque rupture, and found that interleukin 10 was higher, significantly higher, in young SMuRF-less patients versus control. So there's something different about the inflammation in this young group. Now, Intermountain Healthcare, the Jeff Anderson in Intermountain has been publishing and observing for decades now, and put this paper out just recently on SMuRF-less patients in Intermountain Health, which is in the Rocky system, Colorado mainly based. They looked at first STEMI from 2001 to 2021, and again, SMuRF-less was, as defined, was about 26% of patients, and they found that in-hospital and 60-day mortality, death, and MACE was no difference. You can see here that the MACE really maybe slightly right at the edge of being different, but death, no difference. But the SMuRF-less actually were doing a little bit better, especially for heart failure admission compared to the SMuRF MIs. So long-term, SMuRF-less does better, but again, they stated more research needed. But not all studies of SMuRF-less have worse outcomes. If you look at this group, these were registry studies from Austria, Germany, and Scotland and the Netherlands, 2,000 patients, and looked at major adverse cardiovascular events. Here it was total mortality, not cardiovascular mortality, along with reinfarction and heart failure. And they looked at cardiac MR to assess the infarct size and found there was no difference in MI size, no difference in LV ejection fraction, LV volumes, or microvascular obstruction, which you can look at with MR, in the SMuRF-less versus the SMuRF patients. No significant difference. And then finally, what if all patients with SMuRF-less MIs have an infarct, get angioplasty, get PCI? This was 10 randomized trials. They looked at PCI, 2,800 patients, and if you had greater than 0 SMuRF, which means you had risk factors, versus SMuRF-less, excuse me, can we go back there? Thank you. If you can see that the TIMI grade was about the same, the number of cases, much more, again, about 18% were SMuRF-less, but the 30-day mortality was higher in the SMuRF patients, and the 1-year mortality was higher in the SMuRF patients, the patients that had risk factors. So if patients get PCI, as is usually indicated for a STEMI, then there's no difference in 30-day or 1-year mortality or morbidity, at least in the United States. So why be concerned? Well, the editorial that was accompanying this said, we feel there's arisen a degree of complacency in both the research field and the wider community regarding the relative lack of funding for cardiovascular disease research compared with the burden of disease. And I have to say I agree with that. You know, cardiovascular disease is still the number one killer in the world, and it's going to be for a long, long time until we really get ahead of it by preventing it, not by treating it once it occurs. So if you look at what came next was a clinical pathway for coronary atherosclerosis in patients without conventional modifiable risk factors. So it wasn't really a guideline. It was called a JACC state-of-the-art review. It came out less than a year ago. And they tried to show how these patients should be worked up. So what's the suggested workup of a patient you see that has a SMuRF-less MI? These are the headings. I'll give you all the individuals in just a moment, but it's a pretty busy slide. But they talk about blood chemistry, lipids, metabolic factors, talk about sleep, nutrition, oral health. This is extremely important and something that we really don't do much in terms of assessing patients on because we don't feel we have an easy treatment for it. Mental health and illicit substance abuse has gotten to be huge, especially since COVID. Inflammatory parameters are skyrocketing. Cardio-oncology is one of the new and emerged subspecialties. Female and male-specific issues are extremely important. Thrombotic factors, such as lipoprotein A. Additional vascular studies to look like things for like lupus to see if they have prothrombotic situations. And then environmental, occupational, and social factors. There have been a plethora of articles about noise. The closer you live to a highway, the more likely you are to have a heart attack because you sleep poorly and it irritates you. And then obviously genetics are always important. Now if you look at these, at the individual ones, this is why I didn't want to show you the slide, but the colors are interesting. So the blue and black, everybody should get. The red is only certain patients. And I think this is a little much to try to say everybody should get this workup. What I think is reasonable is what we Some of us do, some of us don't. More of us should, me included. Obviously, blood chemistry is talking about sleep and nutrition, mental health, asking about drugs. I've been amazed when I ask about drugs now, and people since COVID that I thought would never be on drugs, and how it's infiltrated even the group you thought, the grandmothers you thought would never take cocaine. Cardio-oncology, history of cancer and treatment. Radiation therapy. Radiation therapy, and I talk about this a lot in my book because I had radiation therapy in medical school for a seminoma. And my inflammatory markers are very, very high. And I know I have a pretty good lifestyle. I do all these things I'm supposed to do. And I started talking to one of our immunologists, and they said, have you ever had any radiation? I said, yeah, I had radiation in medical school. And she said, where was it? I said, well, it was, from Stem Desert, where the cancers were. And she said, that's it. I said, what's that? She said, they radiated your gut, and you have gut permeability. And as many of you are probably aware, that there's 30 trillion human adult cells in our body. There's 300 trillion bacterial cells in our body, and more than that, than both of those combined, of viral cells in our body. And one of the things that the gut microbiome does, it really helps run our immune status. And when our lining of our gut becomes permeable, our inflammatory state goes up. And that's one of the things that is very concerning, at least to me, because I have it. Female-specific, we're all so happy to see some of these female-specific factors come through: preeclampsia, small gestational age, gestational hypertension, endometriosis, early menopause. Our daughter, who's now a cardiologist with me, working with me, is going into a lot of women's health issues. And she said, Dad, do you know how long after a woman has like pregestational diabetes or preeclampsia, her risk for heart disease goes up if you look? I said, probably 40 years. She said, 18 years. Isn't that great to have a daughter that comes and teaches you things you didn't know? Erectile dysfunction in Olmsted County, Minnesota. If you're a 40-year-old man and have ED, your risk of a heart attack is 50 times greater than a man with the same risk factors that doesn't have ED. Ambulatory home BP, and the guidelines now say these markers, these risk or blood pressure cuffs are so accurate to do them at home if you have a regular RDR interval, and put that part of your workup for hypertension. So the primary prevention risk enhancers, inflammation. Now this is from the guidelines, from 2018 cholesterol guidelines that Scott Grundy helped write, and he tried to change the thinking away from just a simple equation for the risk score, but start to think about inflammation for primary prevention. And his things that they pointed out in the committee were ethnicity. South Asians have much greater inflammatory markers. Chronic kidney disease, we know, is a real cause of inflammation. Metabolic syndrome, the fat we have in our adiposity is quite pro-inflammatory. Conditions specific to women, as I talked about, inflammatory diseases like rheumatoid arthritis and psoriasis. Remember, even degenerative joint disease increases inflammation, increases risk of heart attack. Doesn't have to be a fancy psoriatic arthritis. Family history clearly is a big issue. The lipid biomarkers, elevated LDL, triglycerides over 175. You heard about icosapentaethyl. That's very helpful in these patients with high triglycerides. And then certain things they suggested doing that I think is really worth remembering is doing LPA, lipoprotein A, if patients have a family history of early ASCVD. And this is in the cholesterol guidelines. This came out years before the guidelines or the update did for the SMuRF-less heart attack. And then also check an ApoB if their triglycerides are over 200, because sometimes the calculation we do is a little off for the LDL. So this is back to the article from Figtree and Jack on the guidelines, or the kind of the practice parameters. And they really do point out some things that are very important. Sleep health, as we talked about, extremely important. Nutrition now is the #1 cause for early death in this country and in this world. Nutrition. Why? Because 60% of the calories of our young people, meaning less than age 30, are from ultra-processed foods, which are very pro-inflammatory. Environmental and social factors, extremely important. The noise, and I'll talk to you about another environmental factor in just a minute. That's one of the scariest things I've ever seen for risk factors for heart disease. And then finally, physical activity and sedentary time. Gee, has that been a problem the last few years that we're sedentary? Of course it has. So the SMuRF list, the highlighted suggested workup, is patients with CAD and MI lacking modifiable risk factors face high early mortality. That was what the JACC article pointed out. Evidence-based pathway is introduced to guide management. An international multi-center registry may be helpful, and they actually have one mentioned in the article if you have a patient you want to enroll in the registry. But I want to bring you back about 20 years to Salim Yusuf's Inter-Heart study, which was a fantastic study at the time. Salim studied heart attacks around the world, every continent that was populated, so it means every continent except Antarctica. He enrolled patients, or he and his groups and colleagues enrolled patients. And they found that 90% of the population attributable risk for MI can be accounted for by 9 modifiable risk factors. Now, smoking, hypertension, diabetes, and lipids were the 4, but look at the other 5. Dietary patterns, waist-hip ratio, not BMI, but waist-hip ratio, again, getting at inflammation. Physical activity, psychosocial factors. He was one of the first really to point that out in a big scale. And then consumption of alcohol. In fact, what he pointed out was that in the Inter-Heart study, and just to orient you, that the red, if you do more of it, you increase your risk. Green, more of it decreases risk. And then finally, here is the line of identity here at 1, right in the middle. And that smoking and underlined or with a line through it, if it's pink, it's a woman, if it's a blue, it's a man. You can see that clearly the big risk factors will increase your risk for a heart attack. Eating fruits and vegetables, exercising will help you. And he pointed out 20 years ago, what we just thought we learned a few months ago, was that women respond better to exercise with greater reduction in risk than men do from the same exercise. Alcohol, same with alcohol in women. And then ApoB, which is their surrogate for LDL, or our surrogate for ApoB is LDL, I should say. But they found that if all these factors were present, your risk was increased 256-fold. Again, what Framingham told us 60 years ago. When you combine the risk factors, they're much worse than when they're alone. And this is a recent article that probably many of you have seen, but it talks about residual pathways in CV prevention, primarily inflammation, not just cholesterol, inflammatory, thrombotic, triglycerides, and LPA and diabetes, all which are pro-inflammatory. But the markers, the treatments, and then the randomized trial evidence. So all these factors need to be paid attention to reduce our patients' risk. Are we doing that? How are we doing in this country? This is an interesting look at our expenditure. This is healthcare expenditure in the U.S. per capita versus life expectancy. And what you can see at the bottom here is life expectancy at birth. And here is the healthcare expenditure per capita in 2019. So the U.S., we spend for our lifespan about $11,000 per capita with a lifespan of about 77, 78 years. Australia spends half as much as we do. Their lifespan is about 8 years longer. Chile spends 1/10 of what we spend per capita. Their lifespan is about 4 years longer. And there are some countries in Asia and some countries actually in Africa that spend less than $1,000 per capita, and their lifespan's the same or longer than ours. So what's going on? What else are the other factors we haven't talked about? I don't know if anybody saw this recent New England Journal of Medicine article that was about plastics. And the plastics, this isn't like for the graduate, go into plastics, young man. This is more like anti-graduate. Get away from plastics, everybody. So data from the CDC has suggested that plastic additive chemicals are present in the bodies of nearly all Americans. So the New England Journal article just a couple of weeks ago looked at nanoplastics and plaque. They did carotid endarterectomies, pulled the plaque out, looked at it under electron microscope, and found that there was inside a living macrophage, there are evidence of plastic, that it's being eaten and absorbed, digested, just like they would do cholesterol, which is a foreign body in our plaque. Cholesterol should, our arteries were not made to be a storage facility for cholesterol. When it's there, it's abnormal. The body tries to send white blood cells in, get rid of it, push it out. Our plaque in our heart will get warm, just like a splinter in our hand. When the white blood cells go in there and try to push it out, they push it through the skin, it ruptures. The same thing. There have been billions of dollars, or at least hundreds of millions, spent trying to measure temperature inside coronary arteries to see when that plaque is going to rupture, and no one's been able to figure it out yet. If anybody can, it'll probably be CT that'll figure it out, maybe MR. But the plaque, the foreign body, is now this polyethylene and polyvinyl chloride. So they said, we looked at these patients that had coronary arterectomies. They had these plastics in their carotid plaque. They had elevated expression of inflammatory markers. Here were the patients with the micro and nanoparticle plastics, and here are the patients that didn't have the plastic. And by the way, about 60% of the plaques they took out had a plastic in the plaque. And New England Journal said, well, so what? Give us some data. So then they followed the patients for 6 years, or 40 months, 3.5 years, and found that their incidence of non-fatal MI, non-fatal stroke, total mortality was increased 4.5-fold in the patients that had the plastics versus the ones that didn't. So plastic bottle use, and it's not just plastic bottle. Look at the pipes in your house. They're PVC, underneath the sink. These micro and nanoparticles in plastic leads to infiltration in the plaque, which leads to white blood cell infiltration, which leads to current events later. Now, this is a hypothesis-generating article at least, and we need a whole lot more articles like this that show it, and I'm sure there'll be many more coming out. But this is something that, if you go to a foreign country, you cannot drink from something other than a plastic bottle, because you rather get sick 10 years from now or 20 years from now than tomorrow on the plane. So SMuRF-less MIs, key points. Different thresholds for risk factors. To me, this is confusing. I like to have one definition. I think it's what we ought to really migrate to, a single definition for these risk factors. If a STEMI is treated with PCI, there's no difference in outcomes. There's no ethic difference in outcomes. U.S. studies have shown SMuRF-less do better in the short and long term. That may be because we use a lot of PCI. And that lifestyle and inflammation are primary causes currently. And 10% really, or less than 10% of the population in this country are truly SMuRF-less. So I'm going to have a little sip of water from this plastic bottle, and if you have any questions, I'll be glad to try to answer them. Thank you.